weird to say, it's kind of weird to say back in February, because February seems like such a long time ago and so much has happened in that time. But with with the success of that event and the growing number of running medicine providers here at Emory Sports Medicine, we were able to establish a first of its kind medical provider relationship with the Atlanta Track Club and its elite athletes program, which gave birth to the Emory Running Medicine Program. It's our hope today that this program will provide each of you with timely, practical information that you'll be able to put into immediate and often use in your daily interaction with or treatment of runners. We also hope that we can showcase how we do it here at Emory, how we practice collaborative, integrative medicine in caring for all of our running athletes. So with all of that being said, I would like to turn over to my co-director, Dr. Sarah Reiser, to introduce herself and give you some meeting logistics. And again, welcome to the 2020 Emory Running Medicine Conference. Sarah?
Hi, good morning, everyone. Dr. Mason gave a great introduction and he's got quite the background in terms of his running background. I'm going to tell you a little bit about my background as well, and then give you a few logistics as we go through the conference today. So a little about myself. I do work at Emory. My primary location is up at our Johns Creek location, kind of northeast of Atlanta. And I'm trained as a non-operative sports medicine physician as well. My background is in physical medicine and rehab. And I actually had the opportunity to train with quite a number of running medicine specialists during my training at University of Florida, University of Virginia, and out at Stanford. So I've enjoyed kind of having my subspecialty here at Emory in running medicine along with Dr. Mason. I was previously a competitive runner as well as a triathlete. I would say I do a little bit less of that these days, but I really enjoy working with overuse injuries. So I enjoy kind of the mystery of trying to figure out what's going on from a biomechanics standpoint, nutrition standpoint, and psychological standpoint, and really treating the athlete as a whole. This is something I carry over to my other athletes as well, but I particularly have a special place in my heart for the runners in running medicine. I'm also really excited to be offering run gait analysis here, getting referrals specifically for that, both virtual as well as in person. And then I'm going to chat about a couple of my colleagues who are offering similar services. We're doing a lot in terms of trying to develop this running-centric healthcare network. So that's consisting of our physicians, our physical therapists, including physical therapists kind of outside the Emory realm as well, and dietitians, basically so that when we get a runner who comes into clinic, we can make sure that we're giving them or directing them to the correct services that they need to take care of them the best that we can. An exciting new development is that we have a new multidisciplinary bone stress injury clinic that Dr. Gleason and Dr. Ananthakrishnan have actually put together and started, and I've also been taking part in. And with telemedicine being a big thing now, we've actually been able to do it all virtually, which has been even more convenient for getting so many healthcare providers and patients together at the same time. So we include sports medicine physician in this, as well as psychologist, endocrinologist, and dietitian at this point. And so far, it's been a really good success. So in terms of my current team coverage, I cover South Forsyth High School or Emory College athletes, specifically taking care of their runners, and then our Atlanta Track Club elite team, as Dr. Mason chatted about. So getting into our first section, I do want to give a little information. We do have our Q&A tab that's down at the bottom. So if you have any questions as we're going through our sections, feel free to put them in the question tab. We'll make sure we try to address those at the end of each of our speakers' talks. There is a chat icon open, so if you have questions, any technical difficulties, certainly feel free to put them in there. You'll see that Janine Holmes and Chelsea Richardson will be kind of manning the chat and doing a lot of the behind the scenes work, which is absolutely necessary for this. So I thank them for their role in this conference. If any questions come up, like I said, throw them in the chat. Otherwise, we'll go ahead and get started. So we're going to start out with our healthy runner section. So we know lots of people can go out and run, but can we do it in a healthy way from a training perspective, from a nutrition perspective, and preventing and treating overuse injuries? Our first speaker is going to be Jason Roberts, and he's going to be talking on the practical tips for common runner ailments. Jason has been a part of our Emory team for the last year and a half. He's a certified athletic trainer working with the Outreach Athletic Training Team for Emory. And he's currently working with Lovejoy High School and then, of course, with our Atlanta Track Club, our elite team. So without further ado, Jason, if you'd like to go ahead and share your slides, and you can go ahead and hop on.
Good morning. Thank you, Dr. Reiser. As I get my slides shared here, just to let everybody know, for those that have not heard of athletic trainers before, athletic trainers are certified healthcare professionals that do everything from prevention, recognition, diagnosis, treatment, and rehabilitation of athletic injuries. Very traditionally, athletic trainers are found in professional and collegiate sports, but the scope of athletic training is broad enough that we can be found in a number of other settings, including high school sports, working with the military, performing arts, and even in the industrial setting, as well as others. So like Dr. Reiser said, this morning I'm going to work on giving you all some practical tips for common runner ailments. So we are going to get that started. So first we're going to kind of give you a brief overview of some of the relevant anatomy. We'll kind of go over those runner ailments. We'll go over some key rehab exercises that will help with those ailments, give you a few daily reminders, and we'll take some time for questions at the end. So to begin with, to kind of go over some of the relevant anatomy, if we start on our left photo here of the whole leg, really want to point out the gluteus maximus and gluteus medius muscles. Those, obviously gluteus maximus works for hip extension. Gluteus medius is a very important muscle in controlling hip abduction, provides a lot of stability for our hips. That'll be kind of very relevant for the exercises that we go over later. We will be covering some issues with the IT band. We also want to point out gastrocnemius and soleus here that make up the calf muscles attaching into the Achilles tendon. Looking at our foot, these are kind of a couple cutaway views of the foot. The foot has several layers to it. The one layer that is worth noting that's not shown here is the plantar fascia that kind of sits on the top or on the outside of these two layers that are shown. Kind of on our left photo here, we do have some of our foot intrinsic musculature that attaches in and inserts all on the inside of the foot. So to get into some of the ailments we're going to talk about, just so you know, these slides are the most common signs and symptoms and kind of daily maintenance tips. Obviously, it doesn't mean that it's going to cover everything that could happen with one of these injuries. Obviously, if you're doing something that is a little bit unique, you may not be covering these slides and you're not sure what to do. Obviously, you should seek out evaluation by a licensed professional. So we are going to cover patellofemoral pain syndrome, iliotibial band syndrome, plantar fasciitis, Achilles tendonitis, and medial tibial stress syndrome. So starting with patellofemoral pain syndrome, which is also commonly referred to as runner's knee. Typically, you're going to have a gradual onset of pain, and typically you're just going to have pain that pertains to the kneecaps, either behind, underneath, or around it. You can typically have pain with loading of that joint. So that said, some of the things we can talk about with that as far as our daily management is going to be activity modification. So working on reducing activities that load the kneecap and the patella. In this case, it could be running less hills, less stairs. If running in general bothers you, maybe we reduce our running altogether and we work more on cross training from that standpoint. You do want to address some flexibility issues. Again, everybody's flexibility issues may be a little bit different, but for this, you typically want to focus on the quad and hip flexor with it. As far as our rehabilitation, our quadriceps and hip flexor strengthening is going to be key. You really want to kind of focus on open chain exercises for the quadriceps strengthening, which just means your foot will be moving throughout the activity. You don't want your foot to be planted in this case. So example of doing like a quad extension machine would be an open chain exercise for this. Moving on to iliotibial band syndrome, or ITBS. This actually kind of has an unknown etiology. It's kind of widely debated as to how it happens. You typically with this can have localized lateral knee pain. At first, your pain is going to present at the end of activity, and then as the condition worsens, you'll have pain during the activity as well. For, again, our daily management, we want to talk about activity modification. In this case, cross-training would be a good idea. And that you have to be careful of, for those of you that do cycle as well, if you're cross-training, cycling can exacerbate this issue and kind of put you in a worse situation than to begin with. As far as our rehabilitation, we really want to focus on stretching that is specific to our iliotibial vein, our tensor fasciae lata, which is one of our hip flexor muscles, and our gluteus medius. Strengthening should begin once stretching is pain-free. You do want to focus on the gluteus medius strengthening and core stabilization to provide stabilization to the hips and throughout. There have been folks that have found orthotics to be helpful with this condition. Moving on to plantar fasciitis. Pretty common sign symptom is heel pain. Typically, your first step of the day is going to be very painful. Kind of as you move throughout the morning and keep walking, that pain goes away till you get later in the day when, after long periods of standing or walking, you're going to have a little bit more pain. For our daily management of this, our activity modification would be to have some shorter runs. You also want to reduce the number of workouts that you're doing. Workouts tend to be a little bit harder on the foot and exacerbate the condition a little more. So we want to reduce that while we're working on getting this under control. As far as our rehabilitation, you really want to focus on stretching the gastrocnemius, the soleus, and our great toe extensors, which are all areas that you can find some range of motion and flexibility deficits. Strengthening of the foot intrinsic muscles, some of your posterior tibialis and your gluteus medius are all important. Icing for this can be very helpful. Putting a frozen or water ball in your freezer, freezing it, and then rolling your foot over the top of that works very well for it. It's also been found that NSAIDs or non-steroidal anti-inflammatories can be helpful. So things like ibuprofen or Aleve. Moving on to Achilles tendonitis. This is another one where you're going to kind of have a gradual onset of pain. Can have an increased pain with hills and sprints. You can also have decreased calf flexibility from it. You can be a little tender and warm to the touch, as well as a possible thickening appearance of the Achilles tendon itself. So for this, if running on flat ground works for you, that's wonderful. Typically, you do want to avoid hills and reduce your workouts because, again, much like plantar fasciitis, those two things are going to exacerbate, put more stress on the Achilles tendon than it can handle at the time. For our rehabilitation, we want to focus on foam rolling and stretching of the gastroc-soleus complex. And then strengthening can be incorporated as well as tolerated. For this, we really want to focus on eccentric exercises. Eccentric is just the controlled lengthening of a muscle. So in this case, doing calf raises will be a great exercise. And what you really want to focus on is once you're at the high point of your calf raise, that slow controlled lowering back down. Ideally, if you can do it on a step, so you can get a little bit past 90 and really lengthen out the Achilles tendon as long as you can, that'd be excellent. Folks have found that heel cups are beneficial for this in the early stages of management. It just kind of takes a little bit of, you put this in your shoe, takes off a little bit of the stress on your Achilles, kind of helps let you heal up a little bit as well. And last, we have medial tibial stress syndrome, which is also commonly referred to as shin splints. So this is just pain over the middle or distal third of the posterior medial tibia, which is just a nice way of saying kind of the inside of your leg there, right behind your shin bone. You will be tender to the touch. Pain is going to increase with prolonged activity. You can have some tightness of your gastroc-soleus complex, as well as some lower leg weakness if the pain's bad enough for you. As far as activity management goes, cross-training and rest are very important for this one and trying to take some time away from running. A lot of times the pain is there simply from all the pounding that we do as running. So if we can get off and get away from running, kind of do some non-impact cross training, ellipticals, swimming, cycling, things like that would be helpful. As far as our rehabilitation, again, we really want to focus on the gastrocnemius complex for our stretching. As far as strengthening goes, we really want to focus on the gluteus medius, getting posterior tib, and some of that foot intrinsic strengthening. Ice massage, just taking basically a frozen cup of ice and kind of rubbing it over that area for 10 or 15 minutes after a run is very helpful. Taping for your arch support, as well as orthotics, have been helpful for this. So moving on to some of the key rehab exercises. So we have 4 exercises that we're going to go over. 3 of them are glute-based. 1 of them is aimed more at our foot intrinsic musculature. In saying that, all these exercises are going to be helpful for the ailments that we talked about today. Generally, what we kind of want to focus on with every lower body injury that we do is really focus on hip strengthening. Hips are where a lot of our stability comes from as we are running. So if we don't have strong hips, we have and unstable hips, we have unstable knees, which lead to unstable ankles, which all causes injury. So if we can start by stabilizing our hips, that's helpful in trying to prevent some injury from there. As well with these exercises, if you would like to try them as we go along, feel free to do so. For our first one, for arch lifts, our starting position is going to be standing or seated, feet flat on the ground. If you can do this without shoes or with shoes on. If you're still in bedroom slippers this morning, that is perfectly all right as well. Our movement that we're going to focus on is keeping our big toe straight. We're going to hinge at our metatarsal phalangeal joint, which is this big joint right here that we're circling on the screen. And we're going to apply pressure through your great toe. Some cues to kind of think about as you're doing this. You want to think about kind of grounding through your big toe, keeping that straight and good pressure through it. Movement is going to be limited for this. You're really more just feeling for the muscles in your arch to engage. There's not a whole lot of movement. So this is different from a toe scrunch, which a lot of people do, whereas we're not really looking for that movement of the toes. We're really just working on putting that pressure through that foot. Moving on to sideline straight leg raises. Our starting position for this, you're going to be lying on your non-affected side. You're going to bend your lower leg at the hip and the knee for stability. You're going to keep the top leg straight. You want to think about making a straight line from your shoulder through your hip to your foot. Our movement for this is we're going to be squeezing your glute, keeping that straight line. You're going to raise your leg up just above shoulder height, then slowly lowering it down. Some keys to think about as you're doing this is you really want to make sure that your hips stay perpendicular to the ground as you do it. It is very common that when you get tired, you start to kind of roll your hips back a little bit. And that way we're substituting more of our hip flexor muscle than our gluteus medius, which is what we want to be working. When you're doing this, you should feel your gluteus medius engaging kind of right behind your hip bone. These exercises are also, when I first started working with the Atlanta Track Club, they taught me they are affectionately known as Jane Fondas. It took me about a week to figure out why everybody was referencing Jane Fonda. This is why. Next, we have our glute bridges. Our starting position, you're going to be lying on your back, bending your knees and hips to be able to place your feet flat on the ground. With movement, you're just going to squeeze your glutes, raising your hips off the ground until you have a straight line through your hips to your knees. Then you're going to slowly lower it down. For your cues for this that you want to remember about is you want to think about putting pressure through your heels, which will help get us a greater glute contraction as we do it. You also want to maintain a strong core contraction throughout the entire exercise. Once two-legged glute bridges become easy, you can transition to doing them single leg. And finally, our last exercise that we'll talk about is planks with alternating hip extension. So you're going to start in your standard plank position on your toes and elbows. Movement, you're going to hold the plank position, squeezing your glute and raising one leg off the ground. You're going to hold that for 5 seconds, lower it to the start position, and then raise the other leg. You're going to keep alternating legs, to the allotted time of the plank. Some cues to think about as you do it is maintaining a strong core contraction throughout the entire plank. When you're lifting one leg, you really want to focus on keeping your hips and back flat. You don't really want to rotate your hips, or you don't want to sink as you do it. So a few things to leave you with, just some daily reminders. One is to develop a routine. When we become injured, it's really easy to kind of let the brain go haywire and think, oh, I need to do X, Y, Z, trying to get everything better. You know, I need to have this big workout to do. It's easier if we break it up into a daily routine or an every other day routine. These exercises aren't necessarily something you're going to have to do 3 times a day, every day until you get better. If you find your routine that you're either doing before you run, or after you run, find something that works for you and be consistent with it. Consistency is going to be key here. We also want to let pain be our guide as we go through. A lot of times we kind of give my patients a cue to remember on the pain scale. We want to stay somewhere around a 3 out of 10 on the pain scale. Typically, if folks don't like pain scales, which plenty of folks do not, the thing I kind of tell them is there's going to be a point where you're running or you're doing your activity and you feel, okay, this is uncomfortable, but I can work through it. And then there's going to be a change where you go, ooh, that hurt, I should stop. And that's generally kind of where we want you to back it off. If you kind of hit that point where you're like, uncomfortable, it's a good place to step away from. Our third daily reminder we want to think of is don't be afraid to skip workouts. I know as endurance athletes, and I'm just as bad as anybody about this, is that when the training plan says we're going to do something that day, we're going to do it. But it's okay to skip workouts. No matter how, if you're feeling bad, if you're not feeling up to it, it is okay to let that go. Maybe you feel better the next day and you're up to it and you're able to do the workout then. But don't be afraid to skip it on the day that the training plan says you have to. And finally, you just want to be patient with yourself. We all want healing to happen overnight, and unfortunately it does not. So it's okay to kind of readjust your goals. Think of kind of set some smaller goals as you're going through these injuries, and just be patient with yourself as you go throughout your injury and your process to get better. All right, I do believe it's time for our Q&A session.
Hi, if you have any questions for Jason, please use the Q&A function at the bottom and he'll be able to answer them for you. Right, Jason, we received a question. It says, have you heard mixed things about foam rolling for ITBS? Do you have any thoughts on this?
Yeah, so my typical rule in this can pertain to ITBS, or it can pertain to really any injury, is I'm okay with foam rolling kind of above or below the area that hurts, but I don't necessarily want to foam roll on that spot itself. That way, if we're foam rolling on that spot, we can just cause further irritation and injury and kind of prolong the condition. But if we kind of foam roll in areas that are comfortable above and below where the injury is, we can still work on some of that lengthening without causing further irritation.
Jason, we had another question. It says, when stretching for recovery, is it best to perform once warmed up?
I think this depends on who you ask. I am all for stretching at any time of the day that you feel motivated to stretch. I think for me personally, finding motivation to stretch can be hard. So it's okay to do it once you're warmed up. It's okay to do it once you're cold. As long as you are stretching and kind of getting those benefits from it, it doesn't necessarily matter when you do it.
Jason, do you have any thoughts on massage guns?
I've used a couple. I think they can be helpful in the fact that they, sometimes they're going to dig a little bit deeper than what you can with your hands. It also does provide a different type of massage than you are going to be able to provide with your hands most of the time. I think, like you said, if you have access to one, they certainly can be helpful.
Do you have any recommendations regarding plantar fasciitis, night socks, or Strasbourg socks?
Yes. So I know they can be helpful. I certainly have not. I've had kind of some athletes give me some mixed feedback on them. Some do enjoy them. Some other of them find them extremely uncomfortable to sleep in and just can't wear them throughout the night. So I think if it is something that you can get through wearing the night and it is helpful for you, by all means, it's something to go for.
Does vibration machines aggravate injuries of the knee?
Is there clarification on what type of vibration machines we're talking about?
There's not additional information.
I think there are a few different types of vibration machines out there that I've seen. I wouldn't necessarily say in my mind that they're going to aggravate conditions of the knee. I think it really depends more on what you're doing on them as opposed to the machine itself at times.
Do you have any recommendations with nutrition changes when recovering?
I might refer to Dr. Reiser on this. I think we do have a presentation later on nutrition, correct? So I'm going to refrain from answering that one in hopes that it is answered later.
Okay. Can you recommend an affordable massage device?
Ooh. I don't necessarily have any recommendations on them. I've only ever used, I do believe it's a Theragun that I have, that I've used kind of in a clinical setting. I haven't tried enough to give a recommendation based on multiple ones.
What are your favorite preventative hip strengthening exercises?
So the ones I did outline tend to be ones that I will give all of my athletes. If there's ever been an athlete that's worked with me, more than likely they've done those. Single leg step downs are also great exercises that I like for the hip. Just didn't quite have time to cover them as well.
All right. There are a few more questions in the Q&A, but we're going to move to the next speaker. And then Jason, if you can stick around, we can answer the questions by typing them into the Q&A function.
Certainly.
All righty. Great.
Thank you, Jason, for your talk. And thank you for all the questions. So we're going to go ahead and move on to the next talk. For those of you who may be just logging on, my name is Sarah Reiser. I'm a sports medicine physician at Emory. And I'm going to be chatting about overuse injuries in the runner and some treatment and prevention. Really going to be talking kind of from a bird's eye view here. So in a lot of the things that Jason has already talked about, I'm going to be hitting on again. You'll see a lot of common themes as I'm talking that Jason has spoken, and as well as our next speakers. So lots of common themes in terms of kind of the general approach to the runner and things that are important when we're talking about mechanics and injury, nutrition, the whole gamut. I have no disclosures. And in terms of objectives, we're going to define overuse injuries and associated risk factors, and we're going to talk about treatment and prevention of these overuse injuries. So why do overuse injuries matter? Why are we even talking about this today? Well, most of lost training competition time is actually due to overuse injury. Typically, it's not acute injuries that are our primary issue that we're dealing with. These overuse injuries often are going to be recurrent if we don't make changes. So this is why it potentially can be something that is something we struggle with on an ongoing basis, or kind of tends to kind of come back or wax and wane. Bone stress injuries specifically make up to 20% of our athletic injuries, and 80% of these bone stress injuries tend to happen in the lower extremity. So you can understand that runners are probably going to be a little higher risk in that case. And we often are talking about bone stress injuries when we talk about overuse injuries in athletes. And you may know the term bone stress injury more commonly as a stress fracture. Bone stress injury is kind of talking about the continuum. So from periostitis or inflammation of the covering of the bone all the way up to an actual stress fracture with a fracture line through the bone. Because pain and dysfunction can persist and wax and wane, these high recurrence rates are really what we're targeting here. And that's a lot of what I'm going to be talking about today, is how do we break that cycle? So how does an overuse injury happen to begin with? Well, if we kind of break it down to a smaller level, we're talking about this repetitive micro trauma, which we can call running. So you go out for a run, you create this trauma, and you get this local tissue damage. You've got to have recovery of this tissue damage. It's actually how we grow muscle. It's how we become stronger. We get more endurance. So that's actually a good thing. It stimulates that growth. But if you have a mismatch and you don't have as much recovery as you do overload, then you can end up having some form of pain or dysfunction. And that's what we call an overuse injury. So that mismatch can relate to any type of stressors. So if you're not sleeping enough, if you're not getting the right nutrition, if you've got mechanics that are putting excess forces through that area, there are a lot of different things that can potentially cause this mismatch and an issue with a lack of recovery and too much overload. So what does this look like? So if you're a runner, what am I looking for? Well, typically we're talking about bones or tendons, but there's some other structures that can be involved as well. And we're thinking about pain, right? So focal pain may start at the beginning of the run, may warm up out of it, or it may get worse during the run. You may only notice it after runs. So there's a lot of different ways this can present. You may see swelling, you may not. There could be bruising, there may not. Sometimes these can be very insidious. And a lot of times you look at the athlete and you have no idea they have something going on. Impaired performance is really when we end up seeing these athletes for the most part. So it's the day that they go out for a run and they can't complete the run, or they start watching their numbers start to drop. That's when we're typically going to see these athletes come into clinic and say, hey, something's wrong. So what if I don't treat my overuse injury? I don't go to the doctor, I don't take time off. Well, these injuries can actually result in really traumatic injuries that are potentially can require surgery. So in these particular cases that I have listed here, a bone stress injury can turn into a fracture. In a critical location like the femoral neck, we're looking at a hip x-ray here. That fracture in the neck can actually displace and require surgery, which is a big deal when we're talking about anyone, but certainly a runner who wants to get back to high impact activity. On the right side, you can see a tendinopathy that's eventually resulted in a rupture. And that could be an acute injury with a mega force, or it could be something that just kind of the straw that broke the camel's back and results in a rupture that again can require surgery in someone who's very active. Ultimately, what I'm talking about for the most part today is that these untreated overuse injuries can result in this ongoing poor performance. So yes, we see these acute injuries and kind of end-stage severe injuries, but a lot of times this looks like someone who has this nagging Achilles tendonitis, or they have shin splints that are just persistent and they take a little time off and the pain comes back. And there's something that's not being changed in that habitual cycle they're going through to be able to cut the cycle of their overuse injury. So I like to talk about, I know it sounds boring to talk about theories, but I actually have two theories that I really put a lot of what I do in clinic that I'm really basing off of. So this Ledbetter's principle of transition is the idea that there's something that changed that overloaded the athlete that they just couldn't quite keep up with. So maybe this is a change from really supportive shoes to really minimalist shoes that require muscles that that athlete wasn't ready, didn't have and wasn't ready for. Could be someone who's increasing their training regimen and did it a little too quickly and they couldn't accommodate. Maybe they started running on a hard surface and they weren't used to that. So a lot of different things that can happen. And the key is that this transition often happens months before you see the pain or dysfunction appear. So athletes might think, well, I didn't do anything different yesterday. But the question is really, what have you done for the last 3 to 6 months and sometimes even years? But where did the change happen that the athlete was not able to keep up with? The other theory is this victim and culprit theory. So a patient comes into clinic, they've got shin pain. Well, I call that the victim. So that's the pain or dysfunction. That's what brought them into clinic that is preventing them from running. But what is actually the culprit? What's responsible for causing this pain or dysfunction? This isn't usually the shin's fault. Usually there's something else that's going on. So there's biomechanics that are faulty. Could be calf tightness, could be a way that they're running. So specifically in their biomechanics and the neuromuscular setup and their coordination. Maybe they're not getting enough nutrition. Maybe they have huge stressors in their life that have prevented them from getting the rest they need for recovery. So again, we're going to treat the victim, but you'll notice that actually a lot of what I'm doing in my clinic really doesn't have much to do with the victim. It's actually looking for the culprit so that we can break this cycle and prevent recurrence. So you've got the dreaded black line. We're looking at a tibia film or a shin, and that dreaded black line is a stress fracture. So now what? We know we've diagnosed a bone stress injury. We've diagnosed an overuse injury. How are we going to treat this? So first we treat the victim, right? So we're going to protect it. Depending on the injury, we're going to protect it in different ways. Potentially protecting may simply consist of not running or running less or running on different surfaces. Could consist of going on crutches, wearing a walking boot. Again, it depends on what exactly the injury is. The second thing we're going to do is control pain. And a lot of times by changing your activity level, that's going to inherently control pain. But sometimes we're using things like acetaminophen, we're using topicals, your whole price regimen in terms of protecting it, using rest, ice, compression, elevation, all those things are good to do in the meantime. And then we want to monitor healing. So I'm going to bring these athletes back usually on a pretty regular basis, oftentimes around 2 to 3 weeks at a time, that we're bringing them back to make sure we're on the right trajectory, that things are getting better. But this isn't all that we're doing. So we're also supporting the athlete and the whole athlete. We're modifying activity, because if you take a runner who's running 70 miles a week or even 10 miles a week, that athlete is not going to be happy with you. So I rarely tell my athletes that they cannot run. Now, if they have a critical injury, I'm telling them they can't run for a period of time, but maybe they can get on the stationary bike. Maybe they can get in the pool. Maybe they can do upper body workouts, core, and give them something to do during this time, because you've got to be able to get buy-in with that athlete and get them to trust you, and be able to buy into this treatment process. If you have an unhappy brain, you're not going to have a happy athlete who wants to be able to treat this. Oftentimes we're getting folks into physical therapy pretty early. There are a lot of things we can work on, and Jason talked about this already. Core and hips are a really big part of our stability. And so, potentially working on that area, if your injury is somewhere, distally, maybe in the ankle or the knee, and we can safely do other exercises, we can potentially start physical therapy before the athlete's injury is healed. Seeing a sports dietitian or psychologist is also going to be very helpful in some cases as well. So again, we want to find the culprit. So this is what I'm harping on, is we've got to figure out, well, what is the issue? So where is this coming from? Why does the athlete have an overuse injury now? So these are kind of the 4 categories that I think about. We want to look at training errors, how experienced is the athlete, how have their training loads changed, their equipment changed, and any terrain changes. And then the big area that I particularly enjoy working in, and Dr. Edwards is going to go into more detail on this as well, is looking for kinetic chain deficits. And when we talk about kinetic chain, we're talking about joints and muscles and tendons and how everything is connected, because something dysfunction at one joint is actually going to affect other joints and muscles too. Nothing's going to happen in isolation. And we also need to think about the connection between the core and the extremities. So we're going to assess things like posture. We're going to look at relative strength, flexibility. Oftentimes we're seeing tight calves, tight hamstrings, our posterior chain when we're looking at our running athletes. I'm looking at their coordination and their neuromuscular control. So can they do a single leg squat? In this picture here, you can see this young runner actually is having a little difficulty with the squat. Now, I'll admit I had him squat pretty deep. So he actually looked really good, and I had him do a shallow squat. But when I had him do a deeper squat, his knee dives in, his other hip drops, so that right hip is dropping down, and he had trouble controlling his ankle. If you imagine that a runner is running and basically doing all these single leg squats over and over and over, so that's what we think of running for miles and miles. If they can't do a single leg squat in the office, that looks pretty decent. I worry that they're fatiguing and these muscles are not able to keep up with that control that needs to happen to be able to stabilize that lower quarter. And that's going to potentially set them up for injury. So I like to see single leg squats that look really good with good balance and being able to control the knee as well as the movement of the ankle and foot. And this is even potentially out of a shoe too. So he's getting some extra stability in this picture from the shoe that he's in. And then of course, run gait mechanics are important. You don't know what someone looks like until you have them run. So you can look at them on the table all day, but until we see someone move, we don't know how they move. And that's a really important piece. Something that I offer and something that Dr. Edwards offers as well in clinic. And as a physical therapist, she's able to actually hop on and do the retraining piece of it and do the accompanying physical therapy to address issues that she's seeing on the treadmill. In terms of our other 2 categories, nutrition, so important. And it can be difficult sometimes to convince athletes how important this piece is. You are what you eat. So if you're not getting calories that you need to be able to maintain the regimen that you are doing with your running program or any other activity, including things like work, work requires energy too. Even if you're just walking down the hall or you're sitting at a desk, it requires brain energy. So you need to make sure that you're getting the calories that you need. So when the calories are not sufficient, your body's going to start pulling from different areas of the body. Potentially that can mean pulling from the bones so that your bone health suffers or that your reproductive system wants to shut down. There's this culture with female athletes that potentially, not having periods means you're training hard enough. And actually that can really be harmful. That means you're not getting the caloric intake that you need. It means that your bones may potentially be harmed as well. And especially during your teen years and up into the 20s, that's a time that you should actually be building bone, not losing bone. So it's really crucial that we catch these athletes early and make sure that we give them, that they are appropriately consuming the caloric intake that they need for their activity. And that can potentially change on a day-to-day basis. A long run day is going to be different than an easy run day. In terms of other health conditions, so you can't forget everything else. Again, you can't think of any of these things in isolation. So you've got to consider medications that may affect bone health. You've got to think about things like oral contraceptives. So if someone goes to the doctor and they're on oral contraceptives and they have regular periods, well, that's not actually a normal period. That's not necessarily a good representation of what the reproductive system health is like, because the contraceptive is doing that job for them. So taking those things into context. We want to look at malabsorption. Are folks not getting the nutrients they need because of issues in their stomach or their intestines? And do they already have bone mineral density issues? Are they sleeping poorly? Do they have other stressors in their lives? Other psychological stressors can be a big deal as well. So a few training considerations, this first bullet point is actually something that came from one of my mentors when I was at University of Virginia. So this is what he would tell his runners. We deal with these overuse injuries. We don't always take time completely off, but if pain is more than a 3 out of 10 in severity, you shouldn't be running. If you're limping, you definitely shouldn't be running. And if you have soreness after activity that's lasting to the next day, as in, if I do this today, I'm not going to be able to work out tomorrow. That's also a sign that you should not be doing that. Cross-training should really be considered. I think cross-training is a great way to continue to enhance your endurance, to work on strength, and to also help it from the mental aspect. Sometimes taking a break from running and doing another activity can be very helpful. But the thing you can't forget is that's still a stressor. You still require extra caloric intake for it. And it's still going to go into the general energy that you're going to be expending that week. You can potentially be at risk for injuries related with that cross-training activity that you're doing. So don't think of the cross-training as kind of a freebie, which I think sometimes we can be lured into thinking, oh, it's not high impact if I'm on a stationary bike or I'm in the pool, but that's still a big effort for your body and you can still have injuries related to it. So you need to be careful as well when you're incorporating that into your routine. Accessory work. So I think this is a really important thing that we forget. Runners like to run for the most part. Now, the runner who likes to weightlift is great because we need that strengthening to be able to be a strong runner. I don't see those too often. Accessory work I think of as kind of this strengthening that you're doing, working on your mobility, working on your range of motion, and also addressing these kind of neuromuscular pieces. So working on your single leg balance and things like that. Things that might seem boring at times, but these are really crucial and important. And I tell my athletes whenever I'm sending physical therapy, not only are we're going to help prevent your re-injury, but we're actually going to make you a stronger runner by going to therapy and having these things addressed. A general rule for preventing injury when you're increasing your training loads is not increasing by more than 10%. Now, if you are a marathoner, you are a professional athlete, there's a good chance that this rule would be really hard for you to continue to follow. But if you are a general population, this rule can be very helpful in terms of trying to avoid risk of injury as you're increasing your training. And another thing that you want to consider is you really don't want to change more than one thing in your training regimen at a time. So if you're increasing volume, you don't also want to be adding intense workouts at the same time. Try to keep it limited to one thing at a time. So what if I think I have an overuse injury? Address it now. Take a few days off, take some relative rest. And if it's not better, you want to see a medical provider. You want to ask, am I getting the nutrition I need? Has my training plan changed? When was the last time I looked at my strength or my flexibility? And has anyone ever looked at my run gait? And what are the life stressors am I dealing with? Is this kind of an acute event because something else is going on as well in my life? And it is your responsibility to take care of your body and to treat it well. And you've got to take care of everything. It's just like a car, it needs all of its parts to work. If you don't put the fuel in it, you can't get anywhere. So in summary, overuse injuries are common and you don't want one. We want to prevent them. The best thing that we could do as healthcare providers is prevent injuries as opposed to having to treat them. So address your aches and pains early. Tell someone about it. Get help from your medical provider. And that could be your athletic trainer that's at arm's distance when you're out training on the track. tell someone and make sure that you get the help that you need. And make sure you're addressing the whole picture. Don't just treat injuries, prevent them. All right, thank you. And I think I went just a hair over, but if there are any questions, I will try to man a couple of those now.
Sarah, we did receive a question. Is there any device that you would help in detecting poor recovery overall from training stress that could have prevented an injury? So example, whoop strap or use of heart rate variability.
Yeah, no, that's great. So I don't have a specific device. You know, I think there are a few things that you can consider monitoring. Heart rate first in the morning is certainly one that you can do. So taking your heart rate every morning and a rising heart rate can suggest that you're undergoing a little bit of extra stress that you may need to look into. You know, we've have even had our athletes take logs. So log each day, how do they feel? And you can do kind of a number scale or whatever scale that you want, but kind of tracking how you're feeling, what's your sleep like? I think all of those things really combined are really important. Tracking, you know, how much you're eating, if you felt like you overate or underate, how the run felt, all of those different pieces, kind of putting that together as part of the puzzle can be very helpful in figuring out, you know, when you might be overtraining and kind of heading things up by monitoring that diary.
Have you seen any research of increased stress fractures in runners with type 1 diabetes?
Oh, that's a good question. I do not know the answer to that question. Not that I am aware of. I could go out on a limb and say, you know, certainly if things were not well controlled and there were issues from that standpoint, or you're struggling with fatigue, you know, that potentially could put you at higher risk, but I otherwise don't have a specific study or research that I'm aware of in terms of that particular risk.
All right, we'll answer one more question and then we'll answer the rest in the chat box. So what are your favorite cross-training options?
Yes, that's great. So for bone stress injury specifically, I'm typically recommending the pool first. I love aqua jogging. That is the number one thing that I recommend, but not everyone can stand it. So aqua jogging, swimming are good, but the bike is also a really good thing to do. So hopping on the stationary bike and doing that if there's no pain. So again, it's going to depend on what the injury is. Sometimes soft tissue injury is going to prevent you from being able to get on the bike as well. But the stationary bike, you know, working on your VO2 max, that's going to translate pretty well in terms of translating into your running endurance and economy. So that can be a really good method too. But a lot of it really is what doesn't hurt. So a lot of times I'm guiding athletes based on how much discomfort they have and also kind of how far out they are from what particular injury.
Thank you.
All right. Thank you for all the questions. This is great. I will try to get to some more of these as we're going through our next talks. So our next talk is going to be getting into our biomechanics. So this is Kate Mahevik-Edwards. She's going to be talking on running gait and understanding the basics of biomechanics. Dr. Edwards is a physical therapist, author, and educator helping healthcare professionals widen the lens on treating and caring for endurance athletes. Endurance athletes and those who care for them often believe that the definition of success depends on physical performance of their bodies and how well they do at a race. Through 11 years of successfully treating thousands of frustrated athletes while navigating her own injuries and health struggles, she believes that an athlete's success is so much more than their body or their sport. That connecting with the whole body requires the tools, knowledge, clarity, and confidence to grasp the complexities and depth of what these people need to perform and be well within and outside of their sport. Dr. Edwards graduated from Emory University with a doctorate in physical therapy in 2009 and received her orthopedic clinical specialist certification in 2011. She is the owner of Precision Performance and Physical Therapy in Atlanta, Georgia. She is adjunct faculty in the Department of Physical Therapy at Emory University. And additionally, she is the author of Racing Heart, A Runner's Journey of Love, Loss, and Perseverance, and co-author of Go Ahead, Stop and Pee, Running During Pregnancy and Postpartum. That one always gives me a smile. All right, welcome, Dr. Edwards.
Thank you, Dr. Reiser. I appreciate it. All right, so while I'm going ahead to share my screen, I did want to say one thing about the HRV question. And there are a lot of apps that are available out there where you can track your HRV in the morning. You just have to look at them on your smartphone. And what it does is you you can use the phone camera to track your heart rate, but then you input your sleep, you input your training load and all of that, and it'll give you a score. And that really helps to prevent running injury if you can really watch that, because it'll tell you whether or not to train that day. Okay, that's not what I'm talking about today though. So here we go. So today I'm talking about understanding the basics of biomechanics. And I love the talks that went ahead because I think they really set me up really well for what we're talking about here. And I would like to say that I could literally talk about this for hours and days. So 15 minutes is not enough time to really get into the details of this. So what you see today is going to be very basic, but hopefully it gives you some understanding of what we're doing. Okay, so excuse me. To keep runners healthy, it is paramount that one has a sound knowledge of the biomechanics of running and the assessment of running gait. I love this quote because I think it is of the utmost importance that we watch our athletes in their natural environment. If you treat a runner or you are a runner, it is necessary for us to watch you run to truly understand how your body is functioning in the sport that you love or in the thing that you're doing that you love. So without watching that, we really don't get enough information to treat and assess you appropriately. So if we're looking at the running gait cycle, I like to put this up just so that you can have a basic understanding of how we measure a gait analysis. And if you look at running and you look at walking, what you'll notice is that there is a few different things, but mainly the float stage. So in running, there is a stage where both of our feet are off of the ground at the same time, and that's called float. So we go through stance, float, swing, and float. A lot of injuries that occur in runners actually are in the stance phase because that's when we load the tissue. That's when we are having to land during our loading response, overcome what we call the braking force, all of that energy, and then having to support our body under gravity and then pushing off and moving forward. So that's a lot of where injury occurs, although it's only 40% of the gait cycle. And then when we're talking about running gait and we're talking about analysis, you might notice that we say things like loading response. So loading response is when you first hit the ground. Mid stance is when we are actually accepting the weight halfway through that stance phase. Toe off is when we're pushing off and leaving the ground. Initial swing is when our leg comes up off the ground, and terminal swing is the end of our swing phase. So I think there are three basic ideas when we think about running gait. And the first one is picking the body up against gravity. And so imagine yourself running bent over at the waist. Bending over at the waist is actually very difficult to run, but it's often how many people do. If you really think about it, when you're bent over, it's almost like you're sitting down, right? And we can't be very efficient if we're doing that. So posture is key in the ability to run. And the way that I look at posture is I like to see that our neck is not sticking out too far, right? We want our neck to come stacked over our body. We want our rib cage to be stacked over our pelvis so that we can be as efficient and move the best that we can. When we do it that way, we can tap into our core better. We can, our posterior line, which is like our glutes and our hamstrings and our back muscles, all of that will fire better. So posture is absolutely key. The other piece is vertical displacement. So vertical displacement means how much you're going up and down during running. It is normal to have some vertical displacement, and it's around 10 centimeters. But once you start to get past that, you start to lose energy up and down, and you're not using the energy you could to move forward. And so again, if we want to be efficient runners with less injuries, we want to use all the energy to move us forward and try to stay out of injury. So that's picking the body up against gravity. The next piece is energy. And I like to think of this as a rubber band. So if you have a rubber band and you pull it apart, that's when we're storing energy. So you take that rubber band and you're storing the energy. The minute you let it go, it shoots out of your hands and probably hits somebody else if you're not paying attention. Well, that shooting out is that release of energy. So we have to think of our legs and our lower extremities like rubber bands. The minute our foot hits the ground in that loading response, we are storing that energy. We are storing that in our tendons. We are storing that in our muscles, right? And then as we move through mid stance and then push off, we are releasing that energy. And so if we're doing a good job with our posture and we're doing a good job not going up and down, then the release of energy will push us more forward. Now, if we're not able to do that because there's some kind of gait dysfunction, muscle imbalance, strength issue, then we might go up or we might not move forward as quickly. So we might lose a lot of that energy that's supposedly being stored. The third component is pendulums. So you'll see in this picture, I liked this picture because you can kind of see what I'm talking about. If you imagine the pelvis as the top of a pendulum and the legs as the bottom of the pendulum, we think about how much of that pendulum are our legs using. So we want our legs to move all the way forward and all the way back. So we want to move into what's called hip flexion, that's bending of the hip and the knee, and also hip extension, which is that nice straightening out in the back. A lot of injuries will occur if there's something dysfunctional happening in this pendulum. I mostly see hip extension, so the back of the pendulum issues, but there are plenty of issues that happen when there isn't enough hip flexion. So that's kind of also what we're looking at when we're looking at gait analysis. So everybody asks me, is there a perfect gait? Are we supposed to run one specific way? Well, the answer is absolutely not. Everybody is going to look different when they're running. However, there are components of gait that we really do like to see. This woman here running looks beautiful in my opinion. She's in the float stage, so she's off of the ground. That leg that's in the back is in beautiful hip extension. Her pelvis and her rib cage are stacked appropriately. Her hands and arms look good. So you can see how her hand is on the outside closest to us. Her right hand is up near the heart and the back hand is near her pocket. That's kind of the arc of motion that we want our arms moving through. It's hand to pocket to heart. So that looks great. Her front leg is in that nice hip extension. And this position actually is setting her up to land very well. So we want that foot to land underneath the center of mass or close to it. So again, people often ask, should I be a heel striker, a midfoot striker, a forefoot striker? What should I be? My answer is I don't actually care how you strike your foot as long as it's close enough to the center of mass that you don't have to overcome a huge braking force. So braking force is when you put your foot out in front of you and you have to kind of overcome that moment. The other piece is leaning from the ankles. So again, I spoke about leaning from the hips or bending forward when you're running. That's a very common thing that happens, especially running up hills, if there's a lot of weakness in the posterior chain or in the core. But leaning from the ankles, if there are any skiers out there, I know we're in Atlanta and there probably aren't a lot of skiers, but I grew up north, so skiing is a really good way to think of it, is when you're in your skis and you're leaning forward in your ski boots, that's leaning from the ankles. The way that you could do it here in the South, or of course in the North, is set yourself up against a wall and lean forward. See what happens. When you lean forward, is your butt still touching, but your shoulders are off? If so, you're probably leaning from the hips. If you lean forward and your chest and your hips leave the wall at the same time, then you're likely leaning forward from the ankles. And that seems to be a better way to be a more efficient runner. Cadence is another question that's often asked. The basic thing to say is that it doesn't have to be 180. A lot of people really strive for that 180 steps per minute. It's the gold standard, but we could get into how that was discovered. But the idea is that a lot of elite runners are somewhere between 170 and 190. And average people are usually around 165, and that's okay. Cadence has to work for you and your body, and you should never increase it more than 5 or 10% at a time, because that could get you in trouble. Symmetry, side to side. So we're just looking at how one side of the body compares to the other and see if there's any dysfunction or imbalances. I talked about the arms and the rib cage of the pelvis already. Okay, so this is my favorite run gait analysis that we've ever done in our clinic. Just kidding. So one of our PTs, who I have to give a shout out to, Casey, is amazing, and she loves to make us all laugh. And so when we do gait analysis, we usually do it in this area on the treadmill. And one day she got into her T-Rex costume so that we could do gait analysis. Good thing her tail didn't get stuck. Okay, so common dysfunctional gait patterns. I'm going to break down a few different patterns rather quickly. So I wrote it out as well so that you can stick with me. Again, I know this is a really short amount of time, but I wanted to at least give you this. So a lot of the things that we talked about today in terms of common injuries, we're going to start with knee pain. So this is often what people with knee pain look like on the treadmill. And that is, this particular runner is a 14-year-old runner. She's top runner in Georgia, history of knee pain. And if you look, we're going to start talking from top to bottom. But if you look, you can see that that rib cage is sticking out a little bit. And I know it's hard to see. I see it every day, so it's a little bit easier. But you can see that her chest is pointing up. And when that happens, her rib cage is not stacked over the pelvis, and that doesn't allow for good breathing to occur. That doesn't allow for the deep core to fire. And a lot of times that'll help turn off the posterior chain, those glutes that we're always trying to strengthen. So that postural piece is very important. And then you'll see that her pelvis is anteriorly tipped. And then if you move down, you can see that her knee, her front knee is not quite as flexed or bent as I would like when she's landing. So this is loading response. You can see her knee is rather straight. There should be several more degrees of flexion or knee bending there to help support when she lands that force that's coming up from the ground. You'll also notice that she's landing on her heel, which again is not a problem, but she does have a big inclination angle. Inclination angle is the angle between the treadmill or the floor and the foot off the ground. So I don't love that. If for her, I would like that foot to be a little bit under her center of mass a little bit more, or her body. If you look at the second picture, you can really see she's got that hip drop. You can tell by her shorts, they're kind of falling down. Her knees are coming in. So that would be, you can see how the standing leg or the stance leg is a little bit rotated in. That's femoral internal rotation and knee valgus. And you can see how her arm swing is out to the side with the left arm. And that's because she's trying to balance her body. So this is a very typical way that knee pain presents. And the reason that we want to look at this and dissect it is because if we didn't see this on the treadmill and we didn't see how she was running, we probably wouldn't know that we had to address all of these components of her gait during exercise and maybe on the table with manual therapy. So the second one is 35 years old, 4 months postpartum, second child with back pain. Again, this is a common thing that we see with back pain, and we'll start from the top. So her rib cage is a bit anterior or tilted up. She's got left side bending. If you look at the second picture, she's bending to the side, causing compression in the facet joints and in the lower back. She's also got some hip drop, which you can see there. She doesn't have, I didn't put this on here, but she doesn't have a lot of hip extension. You can see it on the left side, the leg that's in swing. I would have liked to see her leg going back a little bit further. A lot of times without hip extension, people will use their back musculature. So you really have to get, again, that pendulum that we were talking, get that movement in the lower legs so that she doesn't use things, or he doesn't use things that are not meant to. You can also see that valgus then on the right-hand side. You can see the knee, femoral internal rotation, knee valgus, and that hip drop. And again, the arms are out to the side to help balance her. We only have a couple more, but this is a 54-year-old patient. She has back pain, stress fracture, so a bone stress injury in the left femur. And what we can see here is that leaning from the hips. And I really wanted you to see this picture because, again, this is very, very common. When people lean from the hips, it increases the neural tension in the nervous system, which can impact, you can find that you have really, really tight legs, calves, hamstrings, all of that, but it may actually be coming from your back. Also, that posterior chain, the glutes and everything might be shutting down. You can see that she doesn't have very much hip extension, again, which is part of the reason her back is doing all the work. And she's landing with a very straight knee with her foot out in front of her and high inclination angle. You can also see on the right, she has the hip drop, knee valgus, femoral internal rotation. So again, this is a common pattern for back pain. And then this is our last one. This patient is 30 years old, again, has back pain, which is very common in runners, but it's also something that's almost like an afterthought. They'll often come in with an Achilles problem because they can't run, but then they are also noticing some back pain. And that usually drives me to think there's something going on in their gait. She also had tibial stress fracture, another bone stress injury, and a labral tear. Same idea. If you look at the right-hand picture, you can see the rib cage is tilted up a little bit. She also has some rotation. If you look at the left-hand pictures, her body is rotating to the left. Her arms are definitely not symmetrical or moving from heart to pocket. She's got the thing that I really want to point out here for a bone stress injury is that if you look at the left-hand picture and you look at that landing leg, the right leg, you'll see that the foot is in a supinated position. And you can see that that lateral component or the outside of the leg is really getting loaded during that first initial loading response. And that's a problem. I see that a lot with bone stress injuries. So that was very quick, I know, but the biggest takeaways from this are that gait analysis is key for diagnosis and treatment of running injuries. We get so much information from a gait analysis, and we can really synthesize that information with what we do in terms of our objective and our subjective evaluation, like what's going on in their life, how is their training, what are they doing for recovery, how are they eating. All of that information goes into an evaluation, but this piece, this running piece, is really key to get the whole picture. So you can tell a lot about a runner from their running gait. There is no perfect gait. I want you really to hear that. So anytime you want to ask me like, well, what should I look like? There is no answer. It's different for everybody, but there are ideal components or things that we want to look for. And then again, Sarah really talked about this, and I love, excuse me, Dr. Reiser. And I love working with Dr. Reiser a lot because she does get this. There's so much more to treating a runner than gait, and there's so much more than just exercise. We have to have strong runners. We have to have aware runners. And strength is one of those things that we often forget to do, but you have to load tissue to make it be able to perform the way that we want. So there's so much more to assessing and treating the runner. And that is it. Let me see. Oh, and I'm sorry, I was supposed to put this up too. So this is my company, Precision Performance and Physical Therapy. It's in Atlanta. There's the website, and there's our Instagram handle. We do both online and in-person run gait analysis. You don't have to be injured to come in, but if you are injured, you can come in. We have online programs for common running injuries. Again, in this time of coronavirus, if you're not comfortable coming in, we do have these online programs and are available to talk to you. We also do telehealth, but we do physical therapy, sports performance, and those are books. Great.
Thank you, Dr. Edwards. We have a few questions. So do you recommend gait analysis in the context of injury pain, or is it equally beneficial for injury prevention?
I would say all of the above, right? So there's actually been a few papers out in the recent years that have talked about the benefit of gait analysis for healthy runners, because like much what like Sarah said earlier, I'm sorry, Dr. Reiser, Sarah said earlier, is that a lot of overuse injuries happen over time. Even though it feels like it happens the moment that you have pain, they're coming, right? And so if we can do a gait analysis earlier or do some kind of functional assessment earlier, we might be able to correct some of the dysfunction that we see so that you don't get an overuse injury.
When you do running gait analysis, do you video it, and how long do you take video from each view?
Right, sure. So I do video. We always do video. And we videotape. It only has to be about 10 or 15 seconds. And I like to do the front, the back, and the lateral or the side view. And then I also sometimes go down and really take a good look at the feet. But yes, we video it, and then we break it down and explain it to our client. And you can do this if you're going to do online video. I would say video yourself so that we can clearly see it, not running away like 500 feet, because I get a lot of those videos, but clearly looking at it for about 10 to 15 seconds is good. But you have to run before you do the run gait analysis so that you can kind of get into a rhythm first.
All right. Thank you.
You're welcome.
All right, I'm going to go ahead and hop on here. So I was going to give a quick plug in terms of our run gait analysis. So Dr. Edwards does these at her clinic at Precision Performance and Physical Therapy. I'm actually doing them myself as well, and both of us do virtual and we do them in clinic. So there's a couple of ways. I am going to give a little more information later too, but I see some questions asking about, hey, how do you get scheduled? So we actually have a email account, runningmedicine@emoryhealthcare.org, and we'll actually put that into our chat. If you are interested, if you have any running issues whatsoever, questions, trying to figure out what provider to get to, you can send us a message, give us your name and your phone number, and say, hey, I have a bone stress injury. Who do I go see for this? And we can help get you where you need to go. So that's one way you can get into clinic with myself. And Dr. Edwards has a website, precisionpt.org, correct? So you can reach her there. She has 2 different locations that she works out of, one of which is just north of the main Emory campus. So I actually go bug her down there on a pretty regular basis. We work pretty closely together with a lot of our athletes. And typically when I'm doing a run gait analysis, I'm also collaborating with Dr. Edwards in terms of the gait retraining and working with the physical therapy piece as well. So with that little piece, I'm going to go ahead and get started with our next speaker. We're just a couple minutes behind, but we're doing great. So these questions are awesome. We're going to make sure that we address them. We can certainly do it by typing in some answers. And then when we get to the end of the session, we'll see if we've got a few minutes that we can also try to address some of these verbally as well. So thank you for your attention. I'm going to go ahead and introduce our next speaker. This is Val Schoenberg. She's going to be talking about fueling the runner, so from the nutritional standpoint. And Val Schoenberg is a registered and licensed dietitian. She has a master's degree in nutrition science from the University of Minnesota. She is board certified as a specialist in sports dietetics, a certified menopause practitioner with the North American Menopause Society, and a fellow of the Academy of Nutrition and Dietetics. Val owns Enlighten You Nutrition Consulting LLC, a private practice in Atlanta, Georgia, where she specializes in nutrition for recreational and professional athletes, dancers and performing artists, women in midlife and menopause, and individuals with disordered eating concerns. Originally from Minnesota, Val's experience and expertise come from years of practice in many settings, including eating disorder treatment, Division I college sports medicine, professional dance organizations, and speaking regionally and nationally on numerous nutrition-related topics. Val is another one that I am frequently sending my athletes to as well. Typically, we're all working as a team and giving this holistic approach. So I'm going to go ahead and turn over to Val.
All right, it looks like I'm not able to start my video. So I shared my screen with you. Hopefully you guys can all see that. I don't know what happened with my video, but I'll go ahead and get started. So hopefully you can all hear me. What I'm going to focus on.
I can hear you just great. I'll take a look into the video piece of it and see what we can figure out for you, but go ahead.
Oh, great. Thanks for letting me know. Otherwise, I just start rambling. Okay, so what I'm going to focus on is why nutrition is important for fueling your activity, as well as reducing the risk of injury. And then we'll review some of the foundational fueling or the principles that are important for runners, and along the way, give you some practical fueling tips for the meals and snacks. So I'd like to start off with, and the presentations before this have definitely helped in terms of leading into why nutrition is also important. So in this scenario, we have a runner who's showing up for their activity, assuming well hydrated, well fueled. So we have the proper nutrients on board to do this activity. Then with intense training, prolonged sessions, a lot of things happen. First of all, we deplete those fuel stores. We're sweating and respiring, so we're losing some body fluid and electrolytes. And then there's some changes to the hormones and what we think of as some disruption to the skeletal muscle because of that intense activity. But then when we come in and we do appropriate recovery strategies where we're refueling with carbohydrates, we're rehydrating the body with fluids, and we're repairing that muscle tissue with adequate protein, we not only come up to baseline, but as has been suggested earlier, your body is able to take on these physiological adaptations. So we like to say you really can only benefit from the training that you recover from. And over time, doing this consistently, as you can see in this graph, so we have the bout of activity, we have proper recovery, then your body is going to continue to adapt. You're going to get stronger, have better endurance, those pieces. Now, if you think about in terms of if we're only partially recovering, then what's happening is we're trending that cycle downward the other way. And this is where we start to see some of the consequences of poor nutrition. As Dr. Reiser mentioned, this low energy availability. So we just don't have enough energy available after all that activity to support all these other body functions, the essential functions on our body. Therefore, you might start to see some chronic fatigue. Certainly micronutrient deficiencies such as iron deficiency anemia may show up. Injuries such as bone stress injuries or soft tissue injuries, or maybe you're getting injured more frequently. Increased training, doing a lot more training, but you're not improving performance. And then digestive disorders are also a concern because many runners will complain of bloating or constipation. And unfortunately, sometimes the recommendation is to remove a certain food or a food group like dairy or gluten. And that may not really be the problem related to the bloating and constipation. It could be just a consequence of that low energy availability. There's an effect on mental health, so maybe some decreased coping skills. So if you're interacting in relationships or on teams, this certainly can be a problem. And then for females, this is again where we see absent or irregular menstrual cycles, which is certainly concerning as it relates to bone health, but also for males, some disruption to that hormone milieu. So our foundational fueling really needs to include on a regular basis, adequate energy intake, proper hydration, being well hydrated. And in terms of function, I'm referring to the structure and the function of nutrients for bone health, for your immune system. So as you think of it in COVID time, we have to have appropriate nutrients as well as proper energy to support our immune system, and then those muscular adaptations. So with energy, what kind of energy? Where do we get our energy? And it really depends. It depends on the type of exercise that you're doing. And for runners, we often think of running as an aerobic type activity, but certainly, you know, you might be a runner who's sustaining 40 to 55% of your VO2 max in energy or exercise intensity, as you see here on this graph on the left. And in that case, you know, about 50% of your energy is going to come from those fat stores, but we also are using carbohydrate. And so it's not ever just one or the other, which sometimes people will say, but often with runners, you might be sprinting to the finish or you're climbing a hill. And so it's very real that you're going to end up in an anaerobic type training at certain points. Or if you're doing some cross training, bringing in some resistance activity, recognizing that your body needs to preferentially depend on carbohydrate. So a higher percentage of those calories are going to need to rely on muscle glycogen and those storage forms of carbohydrate in our body. So therefore, the runner's plate really needs to represent this balance. Ideally, we want to focus on nutrient-dense foods, colorful foods, I like to say. And so in terms of carbohydrates, you know, where we have whole grains, good sources of fruits and vegetables, certainly some dairy foods can provide some carbohydrate. We need good high quality protein depending on your food preferences there, and then some healthy fats. So our plate needs to represent that balance of supplying the energy that your body needs based on your activity. So carbohydrates are an essential fuel. As you've seen, it's a fuel that's important for muscular work across all intensities. It's a key fuel for the brain and the central nervous system. So as Dr. Reiser was mentioning, the neuromuscular pieces of that connection with running, you know, that can certainly affect some of the form and agility that we see in athletes. Carbohydrates need to be available to maintain blood glucose levels. And certainly as we have adequate carbohydrate available to the body, it can spare some of those muscle and liver glycogen stores so that we are able to sustain longer activity. So then what about low carbohydrate? I have to bring this up because it just persists in our culture and certainly among the athletes that I work with. So a little bit of background, the claims about a low carbohydrate diet are that if we just downregulate carbohydrate metabolism and boot up this fat oxidation, you know, we have more fat stores than we have glycogen stores. So why aren't we accessing those fuel stores? We drive down body fat, which obviously can, for many people in their understanding, could improve performance. But certainly for endurance athletes, it's, you know, taking care of the gastrointestinal concerns that come along with supporting carbohydrate intake. So this is a lot of where this idea has come from. And in the past decade, we have more and more researchers who are taking a look at this. And what the research is telling us is, even anecdotally in the studies, participants will report poor energy levels. And certainly we see this in the clinic and with many different exercisers that you just kind of start to tank in terms of your activity and energy. The diet is naturally deficient in fiber. Carbohydrate is basically plant foods for the most part. And so that is where we get fiber. And we have a lot of research that helps us understand that fiber is very important in terms of our colon health, our gut health, but now emerging research that is showing us the importance of a high fiber diet on our gut microbiome and the negative effect of a high fat diet on our gut microbiome. The diet can also be deficient in certain nutrients. So if you're going to cut out dairy, then what are those calcium-rich foods you're replacing in your diet? If you're following a low carbohydrate, high fat diet or a ketogenic diet, many people think they're doing a ketogenic diet, but oftentimes it's a high protein, low calorie diet for that part. But a ketogenic diet by nature is a moderate protein, high fat diet where greater than 70% of your total calories are from fat. And this is, you know, certainly concerning when we look at the research around hyperlipidemia, and we're seeing this now in some of our studies of even athletes that are having this, when you're doing a chronic ketogenic diet, certainly problematic in the long term. Important to remember that our body will adapt to whatever you do consistently, whether that's good or bad. So if we're going to downregulate carbohydrate metabolism, which frankly is glycolysis when you think about energy and metabolism, we're downregulating certain key enzymes. So that might be fine if you're maintaining a steady state, but as soon as you need to kick into high intensity or anaerobic metabolism, that carbohydrate metabolism is sluggish. And therefore we're going to see some fatigue and certainly an impact on performance. As we mentioned, the depletion of the glycogen stores and certainly the importance of carbohydrate for the brain and the central nervous system. As we deplete those carbohydrates, we can increase our risk of injury. All right, so if I've convinced you to break free from that, then how much do you need? And again, this isn't someone's agenda to just push a high carbohydrate diet or carbohydrates. This is from decades of research that really inform fueling athletics and sport. And so these are a bunch of numbers, and I don't really like to just throw numbers at people, but really what I want to point out here is that it depends. It really depends on the type of activity you're doing, the intensity of that activity. And so your daily carbohydrate intake really should be tailored to match your training and your competition volume. So in this simple example of a 150-pound runner who's doing moderate to high intensity exercise about an hour a day, you can see the recommendations there and basing it off of, okay, where do we get those carbohydrates and what does a serving look like? And so we can get carbohydrates from breads and pasta and rice and quinoa, from fruit, to a minimal extent, some vegetables, yogurt and milk and beans and starchy vegetables. So I, again, think it's a lot more exciting, nourishing, and pleasurable to think about food versus numbers. So I wanted to just give you some meal examples. So we have like some ideas here for breakfast, lunch, dinner. And again, these are all nourishing, good sources of carbohydrates that not only provide you that carbohydrate, but we have this additive and synergistic effect of the nutrients, the calcium, the protein, the other factors that are coming in to work together in our body. Here's some snack ideas, again, so to provide those necessary amounts of carbohydrate. And I wanted to point out, kind of coming into our season, you know, a lot of times athletes and certainly runners feel like they shouldn't eat sugar or they should cut out certain, like in air quotes, bad foods. And really that deprivation can often backfire. And so recognizing where we have treats, you know, in seasonal treats, certainly having a couple cookies with a glass of milk could be a really reasonable afternoon snack or evening snack to consider. So what about carbohydrate during training and competition? So those glycogen stores, that source of carbohydrate is going to be depleted at a certain point. And so up to about an hour of activity, not really too concerned with having to supplement there. But as we're doing longer than an hour, especially 2 to 3 hours of activity, not only how you're supplementing your activity with carbohydrate, but also the type of carbohydrates become important in your planning. And part of why there's some research around this is because a lot of runners, again, have some GI issues with carbohydrate intake. And so there's this concept of training the gut, recognizing that the stomach is an organ, just like your muscle, just like your heart, that can be trained. And so if you're not used to consuming fluids or carbohydrates when you're training, then certainly at an event or a longer run, you're going to probably have some problems. So working on gradually increasing the amount of fluid and fuel intake during your training is important. So hydration, again, most of our body, or a large part of our body, is water. And so some symptoms of hydration are listed there. And when we're in a state of dehydration, that really can impair performance and has some serious consequences. So if, for example, you weigh yourself before and after activity and you lose some weight, in this example, 3 to 4 pounds, certainly can have a negative impact on performance. So we want to be sipping on fluids all throughout the day, and certainly begin your exercise well hydrated. During exercise, this really needs to be individualized. After exercise, we have a rule of thumb of rehydrating with 16 to 24 ounces for every pound lost, but I really ask people to pay attention to the color of your urine. So we want to be in that 1 to 2. And then daily, really enough to go to the bathroom every 2 to 4 hours. So if you go to the bathroom in the morning and then don't go again until the middle of the day, probably are in a state of dehydration. And then finally, protein. So protein is important in terms of that overall function of many different tissues and functions in our body, including the immune system. So we need to include protein on a daily basis, but someone had asked this. So in terms of recovery, we really want to aim for 20 grams of protein with some carbohydrate after activity. And you can see some examples of what that 20 grams of protein look like. And that's what is essential for the repair of that muscle tissue and those metabolic adaptations. And certainly if you're in a state of injury, those protein needs may be increased. So as we look at, really making sure we're stimulating muscle protein synthesis, the timing, and so your pattern of eating, if you're skipping breakfast, skimping on lunch, and then kind of back ending your eating, that isn't as effective as distributing that protein throughout the day. And this 20 grams of protein has been shown in studies to be this minimum threshold for stimulating that muscle protein synthesis. And there certainly is an upper range. So excess will just be oxidized. So how do we make this happen? This is an illustration of 3 basic small meals relatively and a recovery snack. And it is reasonable that you might need an evening snack as well. So really not difficult to use food to meet your protein needs. If we have adequate energy intake, we're including all those other nutrients, then we usually don't have to worry about some of these key nutrients. But certainly in terms of our overall health, supporting our bone health and the activity, these are some key nutrients that we want to consider in your meal planning and in some cases supplementing if necessary. So the key takeaways are to really give yourself permission to make sure you're eating during your most active time of the day. Don't run on empty. Recognize that there are some signs and symptoms of low energy availability, and often parents, coaches, and even as a runner, you want to pick up on that and then ask for some support. I really recommend avoid eliminating foods or food groups unless it's medically necessary, like celiac disease is an example. And certainly develop a personalized fueling plan. Don't base your fueling just off of what you read on someone else's website, but really what is appropriate for you based on your training and ideally from a qualified sports dietitian. So let's see here. That is all I have. And see if I can start I still can't start my video. I'm sorry about that.
I am not sure why that is. I apologize. It does look like we may have one question for you here. The question is, would you say that there's some nutrients that runners need to consume more over others? For instance, should runners focus on getting more carbs or more dairy?
Well, again, it really depends. It depends on what your current carbohydrate intake, whether you need more carbohydrates. And and also with dairy, you know, some people just don't tolerate dairy very well. So if you don't like dairy foods, it's not something you tolerate, then certainly we just need to make sure we're getting enough protein, calcium, vitamin D, some of the nutrients that we get from dairy, from other foods. So, you know, it's really a personalized recommendation in terms of, again, the carbohydrate intake based on what your activity, what you're doing, and where your current intake is at.
We'll get another question. Oh.
Yep, go ahead.
Are there any concerns for plant-based athletes, endurance athletes?
No, not at all. I mean, there's really, really great examples of being able to adequately fuel an athlete if they choose to follow a vegan diet. When I think of plant-based diets, that's, you know, that can certainly include fish and lean sources of animal protein as well. So, you know, really, everyone really should have a plant-based diet from that standpoint, because that's where we're getting our key nutrients, antioxidants, those kinds of things. But if you're thinking of a vegetarian or vegan pattern of eating, you know, it's going to take a little more careful planning, and certainly relying on cooking at home more so that you're getting those nutritious foods than relying on, you know, some convenience foods, because that's where sometimes that type of eating plan will suffer.
Thank you. What are your thoughts on intermittent fasting, especially regarding training days versus your off days?
Yeah, that's a common question. Thanks for asking. What I would say is that I'm not a big fan of restrictive eating in general. So it would be, why are we looking at intermittent fasting? What are we hoping to accomplish? And in terms of, you know, a lot of times what happens with something like intermittent fasting is you're ending up driving down your energy intake. And so if we have an energy deficiency, we're back into everything that we've been talking about from Dr. Reiser, and we're just not fueling adequately. It depends too. Intermittent fasting protocols could be alternate day fasting. It could be just a time restricted feeding. So, you know, in terms of time restricted feeding, as long as we're fueling around the activity and you're meeting your energy needs, you know, that could work out. It really does depend. There certainly is an aspect to sports nutrition where we think about periodizing our intake. So if you're just not as active and it's kind of an off season, you know, we can take a look at some other protocols that may help improve VO2 max, based on some strategies there. But as a general statement, it really depends on what you're trying to accomplish with any type of an intervention like that. Got it.
Okay. Do you have any favorite books or resources, websites for folks who are interested in learning more?
Oh my gosh, yes, I have lots. One of my favorite podcasts, I would say, is We Do Science. So if you really like listening and learning about science and our sports nutrition from reliable researchers, good conversations, We Do Science by Dr. Lauren Bannock is fabulous. It's very sciencey and geeky. There's a book called Finding Your Sweet Spot, and that's by I'm drawing a blank on her name, Rebecca McConville. So she's a colleague of mine, and it's a fabulous book on relative energy deficiency in sports. So if that's something that you are struggling with, I highly recommend her book. And you can certainly email me or reach out, and I'm happy to give you some other resources. There's a lot of fabulous podcasts, websites, and resources to give you good information.
Perfect. All right, thank you, Val. There are a couple other questions in the Q&A box, so if you have time, you can stick around and help answer those questions. And we'll move on to the next speaker, Dr. Reiser.
All right, and I just want to put in a quick plug, kind of remind you about our multidisciplinary bone stress injury clinic that we've developed here at Emory. And this kind of, again, Val's talk ties into all of this, where nutrition is important. So with our multidisciplinary clinic, we're doing that currently by telemedicine, and we actually have a sports medicine physician. We've got endocrinologists, dietitian, and potentially psychology as well. So really integrating all of those different components into treating things like bone stress injuries and other overuse injuries. And so I think Val really spoke to the importance of being able to address all of that. I am going to turn things over now to Dr. Mason, who's going to introduce our keynote speaker.
Thank you, Dr. Reiser. As everybody knows, as you looked at our conference schedule, we kind of tried to divide things up into kind of generalized healthy running, and then kind of pivoted to the end of the day into specifically, okay, this is the general, this is the specific of the time that we're in now. And to help aid us in that transition, our keynote speaker, Jonathan Kim, is well positioned here. Dr. Kim is an assistant professor of medicine and the chief of sports cardiology in the division of cardiology and orthopedics here at Emory University. He additionally holds an adjunct professorship in the School of Applied Physiology at Georgia Tech. He received his Bachelor of Science at Emory, and he was a Fulbright Scholar before leaving to go to Vanderbilt for medical school. He completed his residency in internal medicine at Mass General and a cardiology fellowship, returning here at Emory to do that, where he served as chief fellow. At the completion of his fellowship, he became a faculty here back in 2014. In addition to his clinical roles, Dr. Kim conducts NIH-funded sports cardiology research here at Emory as a part of the Emory Sports Medicine faculty. He's the team cardiologist for the Falcons, the Braves, the Hawks, the Dream, and the sports medicine at Georgia Tech, and is a member of the NBA Cardiac Advisory Committee and the American College of Cardiology Sports and Exercise Council. That's a mouthful. He is also co-director for the AJC Peachtree Road Race here in Atlanta. Today, Dr. Kim is going to be talking with us about the cardiovascular considerations in the age of COVID. This is something that is right up his alley and a very a big passion point for him. So without further ado, I'd like to introduce Dr. Jonathan Kim. Dr. Kim?
Thanks so much, Amadeus. I'm just trying to start my video here. It's not letting me start my video.
Yeah, we've had a problem with videos starting.
Yeah.
Yeah. Can you see my slides?
Hi, Chelsea. Yes, can you make him a co-host, please? Or Janine can also do so.
All right. He's a co-host. Try now to turn on your video. There you go.
All right. All right. Well, again, thank you so much for that a very kind introduction, Amadeus. And I want to, again, thank you as well as Sarah for the invitation to speak. The attendance is pretty impressive for this conference. So I've been tasked with giving a review on what we know about COVID-19 and the athlete's heart. And again, this is a talk that I've given to medical communities as well. So I will try to tailor this to the audience at hand and try to have everybody have a generalized understanding. And importantly for this discussion, I'm going to talk about what we know, what we don't know, and perhaps most importantly, what the current controversies are. And we'll of course get into the whole return to play conversation. I'm sure that's on top of everybody's mind, particularly given the current surge that we're all suffering through right now. Here are my disclosures you've already heard, as well as my research funding sources. I do have some research funding generously through the Atlanta Track Club as well. So I have three primary objectives for everyone to take away by the end of this talk. To have an understanding about what we know about the effects of COVID-19 on the heart. And this is really important. There's a lot out there as it relates to the media. And it's important to really understand what's fact and differentiate what we don't know specifically then about COVID-19 and the athletic heart. And I'm going to talk everyone through the evolution of current consensus return to play recommendations. And of course, we're talking about athletic individuals who have been infected with COVID-19 and who are desiring return back to training and competition. Let's start off and put everything in the context of sport. And I would submit that March 11th was indeed the day that the sports world stopped. It was a remember where you were type moment. I remember sitting watching the news with my wife, and breaking news, the contest between the Jazz and the Thunder was abruptly canceled right at tip-off in fairly dramatic fashion when it was disclosed that one of the team members for the Jazz tested positive for COVID-19. And it was really over the next subsequent days that in rapid fashion, not only was the NBA season indefinitely postponed, but March Madness was canceled. The Masters tournament was postponed, and spring training was also indefinitely postponed, and the start of Major League Baseball was up in the air. So for many sports fans, for sure, I think this is when the pandemic really became quite real. And then, of course, it only evolved from there. Let's get to the basics of infection, though, and why COVID-19 has a dramatic impact on the cardiovascular system. This is just a summary slide from a couple important reviews. And it really starts at the time of infection. Everybody's heard about this spike protein. Certainly that's when you've heard about the news about vaccination, it's been that protein that's been targeted. And SARS-CoV-2, which is of course the virus that has led to the COVID-19 pandemic, enters the respiratory epithelium via this ACE2 receptor. ACE2 is actually present on other vascular structures as well. And it's upon binding of the virus, entry of the virus into the cells, that ultimately leads to all of this diffuse systemic inflammation, which really leads to all the complications that we see. I think it's important to recognize that COVID-19 is not just a respiratory virus. It really leads to multi-system, it's a systemic disease that impacts multiple systems in the body. This is a very busy slide, but I'll talk everyone through this. And this is really a nice summary as to why we see all of the cardiovascular complications. And if we start at the top, you'll note here that individuals who have underlying pre-existing conditions, particularly cardiac conditions, high blood pressure, previous history of heart attacks or coronary artery disease, diabetic patients, we know that this increases not only susceptibility for infection, but increases your risk for more severe disease. And of course, you can throw increased age as well as some other comorbidities. And again, it's upon viral entry that ultimately we get this cascade, which leads to diffuse systemic inflammation. And all of that inflammation ultimately leads to many of the cardiovascular complications that we see. And so what we can see is what we call acute cardiac injury, which is the release of specific proteins within the heart that we know is indicative of injury. And this is a protein called troponin, which is within the muscle cells of the heart. You can have precipitation of what we call acute coronary syndromes, which is essentially heart attacks, the provocation of dangerous heart rhythms, arrhythmias, which can be life-threatening, as well as the provocation of what we call thromboembolic phenomena, which is basically blood clots. So you've heard about people with blood clots in the lungs. All of that, again, is related to the inflammation. What's somewhat controversial is whether or not the virus can directly invade the heart. And there is some evidence to suggest that it does, if you look at autopsy studies, but also some autopsy studies which suggest it's a different underlying pathophysiology where perhaps there's not as much direct viral invasion. But this is a process called myocarditis, where the virus can invade the myocardium. It leads to diffuse inflammation within the heart. So all of this, again, is a byproduct of infection. And so if we were to summarize what we know about cardiac injury specifically, there are a few important points. Number one, we know that cardiac injury is common with more severe infections. So these are individuals who have symptoms severe enough that lead to hospitalization, whether it's shortness of breath, pneumonia, or other issues related to all of this inflammation. And importantly, this is pretty profound. So almost upwards of 20% of patients who are critically ill will have evidence of cardiac injury. And to put that in perspective, if you compare that with other common respiratory infections, that can still lead to significant disease. You can think of the flu. This is much higher. So around 1% of the time with significant respiratory viral illness, you can have cardiac injury. And for COVID-19, it can be as clearly much higher, upwards of 20%. And when you have heart injury, not surprisingly, that predicts worse outcomes. And we also know that older age, and as I mentioned previously, if you have underlying cardiac risk, whether it be high blood pressure, diabetes, a previous history of heart attack, that also increases your risk for cardiac injury. So severe disease is the big problem. The problem is what we don't know is what about those patients who aren't as ill? So these are your asymptomatic patients. We all know that you can have asymptomatic infection with COVID-19, or if you have mild symptoms, common cold type symptoms, upper respiratory tract symptoms, can you still have significant cardiac injury given how much we're seeing if you're sicker? That still remains an active question. But because of that, that's why we've been so careful for athletes, whether you're a competitive athlete or you're a high-end recreational athlete who trains for marathons, triathlons, et cetera. That really was the impetus for a very conservative return to play approach that we embraced early in the pandemic. So this was the first document that we published. This was in May of this year. This was published in JAMA Cardiology, and this was sponsored through the American College of Cardiology. These were expert consensus recommendations, which helped guide what we felt was an important algorithm before allowing a competitive athlete to return to play. Again, looking for any evidence of cardiac injury, which could be representative of that myocarditis process. Now, there are important limitations to discuss. Again, remember, this was back in May. Number one, we had no idea what the prevalence of asymptomatic COVID-19 infection was. And in fact, if you remember, just generalized testing, clearly testing is still a problem today, but it was even more of a problem in the springtime. We couldn't test everyone. And to this day, we still don't have a great idea about the prevalence of underlying cardiac injury, again, in those individuals who have no symptoms or mild COVID-19 symptoms. And perhaps the most important limitation is these guidelines were released during the national lockdown. So we had absolutely no clinical experience about what we would see in athletes infected with COVID-19 who are trying to get back to return to play. So a lot of substantial limitations. So I'm not going to go through this entire algorithm. Obviously, this is a busy slide, but this was the actual algorithm that was published. But if I was to summarize what the key important point was, it was twofold. Number one, we did not think that if you were asymptomatic, so if you tested positive for COVID-19, but you had no symptoms, we still felt that you probably didn't need any sort of cardiac testing. You could slowly return to play after your self-isolation period. But for those individuals who had any symptom, and we felt whether this was obviously more severe symptoms, but even if you just had mild congestion as it relates to COVID-19, but you tested positive, we recommended a very conservative approach, testing for that troponin protein I talked about, because we can do that. So remember, this is the protein that's released indicative of cardiac injury, getting an EKG, which is an electrocardiogram, and getting images of the heart with an ultrasound, a two-dimensional transthoracic echocardiogram. So important to remember that myocarditis has actually been around we've known about it for forever. And we've never actually had an algorithm where we're screening for myocarditis after any other type infection, even if you have very severe flu. So this was an extremely conservative approach. But again, we didn't know. This was a novel virus, and this was the generalized approach that we recommended. Well, over the next several months, a few things came into play. This was through the summer months. The national lockdown lifted. And I think there were three important things that really stirred the pot, if you will, and increased a lot of the controversy as it relates to cardiovascular complications. First, there were several high-profile athletes at the professional and collegiate level that self-disclosed on their own that they had cardiac issues after a milder COVID-19 infection. There were a couple studies that were published, community-based observational data sets, which we'll talk about because they're important, which suggested that there actually was maybe some evidence of heart injury in patients who were not as sick. And these studies were based off of cardiac MRI. So again, like you can get an MRI of your knee, we can do it of your heart, and you can get really, really detailed pictures of the heart, and as well as if there's any evidence of injury in the heart. And lastly, we all witnessed in real time national governing sporting bodies, universities, professional teams, all struggling with the return to play approach, and even whether just to return to sport. And so if you put all that together, we had a lot of national media attention that was really highlighting specifically on this question of cardiac issues related to COVID. And that only raised the concern about cardiovascular complications. Well, I want to spend a little bit of time focused on these studies because they're important. And again, I'm going to summarize these studies and make this a little bit easier to understand. So this was a study published in Germany. This study generated a lot of international attention. In fact, if you go to the JAMA Cardiology website, it's had almost 750,000 downloads. I mean, it's amazing. It's probably the most downloaded study I would submit maybe in history. And it was a small study. They looked at 100 patients from Germany, all of whom were infected with COVID-19, mild disease, and recovered. So 2/3 of the cohort, 67 roughly, only had mild symptoms. And these were middle-aged patients. And what they also performed were cardiac MRIs. And they found that almost 80% had what they deemed abnormal findings by cardiac MRI. 1/3 of these patients had something called late gadolinium enhancement. You can think of this as basically a way to show evidence of either fibrosis or scar within the heart. And 60% showed elevated T2, which basically means an MRI way to establish whether or not there's swelling or edema in the heart. So that's, of course, an abnormal finding. They performed various statistical modeling, and what they found was that evidence of swelling or evidence of cardiac injury, as defined by these two cardiac MRI markers, T1 and T2, were highly predictive of showing cardiac injury compared to control cohorts. And so they concluded, again, that there was evidence of cardiac injury in patients who were infected with COVID-19, but only had more mild symptoms or even had no symptoms. The problem, of course, is we compare this to athletic individuals, is it really wasn't comparable. When we were focused on younger elite athletes, of course, this was an older cohort, but even if you think about healthy masters level athletes, more than 20% of this cohort had underlying pre-existing conditions, and 40% of the cohort still had symptoms actually at the time of the cardiac MRI that was performed for the study. There are other limitations for this study. It actually generated a lot of attention, some of the issues that they had in their methodology, which we won't get into. But I think the bottom line is it really wasn't a great study to compare to athletic individuals. So more importantly, were a couple of recent studies actually focused on athletes. These were case series. So these were looking at athletes who are returning to play at these individual institutions. This first study looked at 26 athletes from Ohio State University, all of whom were returning to play. And importantly, all of these athletes had either no symptoms or only mild symptoms, all of whom had normal testing. So they had this normal ECG, troponin, and ultrasound that we recommended in our May JAMA cardiology document. But what they found was that 4 of these individuals had evidence of what they called myocardial inflammation, which was consistent with potentially myocarditis. And they use criteria that are published called the Lake Louise criteria. So again, this is how we define myocarditis via cardiac MRI. And of those 4 individuals, 2 were completely asymptomatic. And almost half of these individuals had non-specific LGE. And remember, LGE is a MRI sign of underlying potential fibrosis or scar in the heart. So the authors conclude again that there is evidence of subclinical cardiac injury in patients, and these are athletic patients, who had only mild COVID-19 disease. And they also conclude that MRI would be useful in a screening algorithm to get athletes back to return to play. So the second study, this is hot off the press. This is a study from West Virginia now. Again, exact same study methodology. They looked at 48 athletes, all returning to play. All of these collegiate athletes had either no or mild symptoms. And in this study, more than half had a documented abnormal cardiac MRI. This study actually contrasted with the Ohio State study and what was abnormal, however. In this study, 40% had evidence of pericardial enhancement. So the pericardium is the tissue that surrounds the heart. It protects the heart in your chest. And when it's inflamed, it's called pericarditis. And again, via cardiac MRI, you can utilize contrast to see this inflammation. And in this study, again, 40% of the abnormal studies had evidence of what would be considered pericarditis. But again, remember, most of these individuals had either no or mild symptoms, and certainly not symptoms that were consistent with potential pericarditis. And in contrast to the Roche-Paul study, that's the Ohio State study, none of the athletes in this study actually had the same MRI findings that they demonstrated in the other analysis. So no athletes demonstrated positive Lake Louise criteria for myocarditis. So it actually contrasted a little bit to what the abnormal findings were. But these authors concluded again that cardiac MRI showed evidence of potential subclinical cardiac injury in those individuals with even mild forms of COVID-19. So as you can imagine, both of these studies, particularly the Roche-Paul study, generated significant attention again and concern about all of these potential cardiac ramifications after COVID-19 infection. Now, before everybody panics and again jumps down that train and is concerned about what COVID-19 does to the heart, we have to talk about study limitations. That's really critical. And anytime you have a case series or an observational study, there clearly are going to be limitations that you must recognize before assuming worst case scenario as it relates to some of these conclusions. And most importantly, for both of these two studies, they did not have appropriate control populations. And what that means ultimately is that you can't determine what the clinical significance is, particularly when you have individuals who don't have the symptoms that are consistent with what we typically see with pericarditis or myocarditis. And the key question, which remains to be answered, and this is a really important question, is we have no idea what a cardiac MRI looks like 10 to 14 days roughly after a common respiratory viral illness. Somebody has a bad flu or a bad enterovirus, which is another common respiratory viral illness, which can actually cause pericarditis or myocarditis. We don't know what cardiac MRIs look because nobody's ever really done that type of analysis. And you have to focus on this concept called pretest probability, which we're going to discuss. And again, if somebody's presenting with those symptoms and you typically aren't worried about myocarditis or pericarditis, you have to be careful when you just start obtaining studies. So yes, there are findings via cardiac MRI that were shown by these two studies, but the question, are these significant? Are these findings that we should even care about from a clinical significance standpoint? We don't have comparable normative CMR data in athletes. So some of those fancy techniques I talked about, T1, T2, we haven't defined those in athletic individuals. And that's, again, an important limitation, particularly when some of those abnormalities are just mildly abnormal. And you really have to be doing these type studies in highly experienced centers anyway. And the study methodology, at least in that first study, the Ohio State study, was not well described. And that in part is because it was a research letter. So they were limited in terms of what they could describe. But I think it's important to talk about in a comparable narrative. And so this is something that we have gone through in the sports cardiology community in the past. This is a slide I borrowed from my colleague and friend, Kim Harmon, who's at the University of Washington. And so this goes back to the early 2000s when we talked about how to interpret the ECG in an athlete, using the EKG to look for evidence of heart disease via screening, which would then potentially lead to more testing and to find reasons that maybe an athlete shouldn't be participating in sport. Well, look specifically back to, again, 2005. That was the first time that we had a set of criteria to interpret the athletic ECG. And you see a false positive rate that's completely unacceptable, 15 to 20%. So that means that 20% of athletes that were having quote unquote abnormal ECGs actually had nothing abnormal at all. And these were athletes that ultimately had testing, whether it was an echo or some other advanced imaging study, they were held out for some period of time. And that's obviously not ideal. And of course, if you follow this over time to what we utilize now, the international criteria, it's only about 1 to 2%. So again, it's important to note how when you have a low pretest probability, these are asymptomatic athletes that you're just getting EKGs on, you got to be careful interpreting what you think is abnormal. So this was a headline that actually was, again, look at the date, September 11, 2020. This was right after the Rajpal study was published. And if you look at the subheading, basically it states that cardiac MRI can help determine when those who are recovered from COVID-19 can return to sport. So I would substantially push back on that based off of the limitations that we talked about. And you only have to fall back on what we call the simple Bayesian principle. So in science, that refers to pretest probability. When you look at a problem, what is the likelihood that somebody has something based off of what their symptoms are or what symptoms they don't have? And when you talk about screening tests, that's critical because if somebody has a low pretest probability, you can get a test on them and have an abnormal finding, but it's completely not significant. And then you ultimately go down a rabbit hole. And so we can look at two important documents that we have in cardiology, which really emphasize this important point. So on the left of your screen is what we call the Task Force 3 document. This was looking at sports eligibility for various cardiac abnormalities, and you'll highlight here myocarditis. So these are the guidelines that we utilize to look at athletes about whether or not they're eligible to play if they have certain conditions. And on the right side of your screen, it's actually the Lake Louise document, which was published in 2018. And again, this was a document, again, that talked about how cardiac MRI can help diagnose myocarditis. And I'll highlight two important points. So in Task Force 3, it specifically commented on how we diagnose myocarditis. And number one, a clinical syndrome must be present that's consistent with myopericarditis. So these are symptoms classically of chest pain, shortness of breath, actually symptoms consistent with congestive heart failure even, or arrhythmic type symptoms like palpitations. So that's highly important. You have to have that before you think about myocarditis. And in the Lake Louise document, this is highlighted within the paper, the consensus group that put forth the document recommends that in patients with significant clinical pretest probability, that's when a CMR scan can provide evidence. So what we don't know is if somebody has absolutely no symptoms, you have no idea how the MRI can help diagnose myocarditis. We don't know what the specificity is, and that's a medical research term which basically helps document if there's going to be false positives. And that's the critical point here is remember that an MRI is a very sensitive modality. And if you're finding findings, you just don't know if it's clinically significant. And it's because of these critical points that I think the data don't justify that cardiac MRI is a very useful study right now for screening for athletes who are returning to play. And these are competitive athletes, masters athletes, again, anybody who puts a high premium on exercise performance. So throughout these last few months, I've talked about some of these controversial studies now. Again, there was the controversy of some athletes disclosing that they had cardiovascular issues. There was one other important thing that happened that occurred between the months of June to really the present, or at least into the early fall. And that's the national lockdown lifted and athletes were coming back. Many athletes were returning to the field. Clearly they were returning to train. And while we haven't had competitive recreational events for many months, clearly there were athletes that were starting to come back that were getting back to the regular training regimens. And with that, we were seeing these athletes in our sports cardiology clinics who were infected with COVID. They were referred in or they were concerned. And we were implementing our recommendations that we put forth back in May real time. And what we were observing were a few important observations. Number one, the majority of athletes that we were seeing actually were presenting with almost no symptoms. And many of these athletes were picked up on routine asymptomatic screening, which is happening at the professional and collegiate levels at the Power 5 level, or they had only mild symptoms. So what's a mild symptom? We define this as a mild upper respiratory tract infectious symptom, like a cough, mild cough, congestion, sore throat, runny nose, mild gastrointestinal symptoms like nausea, vomiting, diarrhea, loss of taste or smell, headache, little bit of fatigue, but what we were not seeing were athletes presenting with significant systemic symptoms, persistent fevers, chills, and muscle aches, significant lethargy, and not many that were actually presenting with cardiovascular complaints, whether it be chest pains, tightness, shortness of breath, palpitations, feelings of your heart fluttering. We weren't seeing that. And with the former, which are the athletes, again, who were asymptomatic and had mild symptoms, we were not observing significant cardiac pathology with EKGs, echoes, and troponins. And we recognized that as a sports medicine community, we were struggling with this. Not only that, but we were getting calls from high schools, from recreational organizations such as the track club about what to do with masters athletes who are calling about what should I do with COVID-19? I had it, should I get back to training? Now, there are active forthcoming registries that are being put together. I'm honored to be a part of some of these registries at the professional and collegiate level, but of course, these data aren't published. So we felt as a sports cardiology community, the experts in the field, that we should leverage our experience and help guide this framework, provide a little bit more assistance based on what we were seeing to update some of the recommendations, improve the recommendations that we put forth again back in May. So if we were to summarize what we changed, we did not change our feelings about asymptomatic infection, but for mild COVID-19 infection, again, your mild URI, mild GI, little bit of loss of taste or smell, based on what we were observing, we do not feel that cardiovascular risk stratification was necessary. And at this point in time, recommending that you don't need to have all that extensive testing. Again, important to follow the CDC guidelines for self-isolation, and important to emphasize exercise abstinence, and that's important. Respect COVID-19. We all, again, I know this community quite well, and the best cure for a cold is just to get out there and run. For COVID-19, you shouldn't do that. You really want to just hang tight, don't do anything for 10 days. And then once that's done, again, if you are in that category of asymptomatic or mild illness, you can slowly get yourself back to speed. For moderate severe symptoms, I'm going to first talk about the competitive athlete. We are recommending still risk stratification, ECG, troponin, echo. That continues to have expert consensus of support based on the rationale of what we're seeing among the sicker patients that I talked about in the beginning. I'm going to talk a little bit more about the master's athlete in just a second. But again, and then finally, again, for more extensive testing, as I've just gone through, we're not recommending cardiac MRI as an initial screening test. This should be saved if baseline tests are abnormal, certainly if symptoms are persistent or recur, but not first line. And importantly, what we emphasize is a slow and gradual return to play. And this is for anybody. Don't just go from not exercising to getting back to your full training regimen within the first 24 to 48 hours. Give it time, allow yourself to slowly get back. That's almost the fail-safe mechanism. If you start noticing symptoms, that's whenever you should reach out to your physician, potentially to think about whether or not you need more testing from a cardiac or even pulmonary standpoint. So that's really the change at present. Now, we also had these changes specifically addressed to different populations. First, for the high school athlete, I won't spend too much time here, but we recognize that at least in our clinics, we do see a lot of high school athletes. For those younger than 15 who have more moderate to severe illness, you should follow up with your pediatrician, and it should be individualized about whether or not there should be any testing. Many times maybe you don't, and maybe it's just a slow and gradual return to play, but it should be guided by the general pediatrician. Obviously, people have heard about this MISC, this multi-system inflammatory syndrome in children. That should be watched for. That's a rare condition that can sometimes occur even up to 4 weeks after COVID-19 infection. So those symptoms should be watched for, and that's something that the general pediatrician can guide. Spend a little bit of time for the master's athletes, because I think that's probably a lot of the folks who are tuning in today listening to this. So while we had this return to play for the competitive athlete when the national lockdown was lifted, we haven't had a real return yet to competitive recreational racing. Obviously, we're all aware of that. There have been virtual races for sure, but we haven't had that full competitive marathon. We know about Boston, Chicago, all of our marathons, unfortunately, have been canceled. And so I think for the master's athlete, we're still a little bit in that boat that we were in back in May about what are we seeing in this older population who have had COVID-19. I can tell you that in my clinic, the master's athletes that I have seen that have come to see me after infection have been pretty similar to what we've been seeing for the younger competitive athletes. More mild symptoms, and those that we've done risk stratification for have actually been normal. So I think we want to be careful, though, about saying that every master's athlete who even has maybe some of the moderate symptoms needs an echo ECG troponin. I don't think that's necessarily the case. And when you look at healthcare resources, you have to keep that in mind as well across the country, that that's not that easy to obtain, particularly if every single recreational athlete starts going to the cardiology clinic. And I don't want to endorse that as something we should do. But I do think if you do have moderate symptoms, certainly cardiac symptoms, you want to reach out to start with your internist. And perhaps there should be a conversation. And it may not be unreasonable to have that slow return to play and to look for symptoms that may be persistent, and then decide if there should be more cardiac testing. If you do have underlying cardiac risk factors, if you have a cardiologist, if you're older than 65, which is what we commented in this algorithm, reach out again to your cardiologist and have that discussion about how much of this testing you should have, if any of it. But regardless, there should be that slow resumption of play. And that's something that we emphasize. We wanted to be careful and not mandate this as something that every recreational athlete should have. And then, of course, we updated our competitive athlete that I just talked about. So if I were to summarize where we're at in November 2020 as it relates to COVID and cardiovascular complications, would be a few things. Number one, it's pretty clear that for those patients who are sicker, who are hospitalized, who have severe symptoms, and that those individuals who are older, who have underlying pre-existing conditions, are at risk for this. What we don't know, what still remains to be determined, is the prevalence of cardiac injury in those who have mild symptoms or who are asymptomatic. The observational data looking at athletic individuals are still limited. We're still trying to design what the best return to play approach is. So we await important forthcoming registry data. We still need more of these type studies to define disease pathogenesis and to figure out what the appropriate return to play algorithm is and how some of these more advanced studies can be helpful. However, we still need to respect the virus. So we have to have a cautious approach to return to play. It's got to be pragmatic though. So for competitive athletes, you've heard the recommendations that we put forth. For recreational athletes, again, perhaps the cautious nature is about the slow return to play. So if there's a message that can be put forth, For your friends who are not listening to this and who you've known that have COVID right now, or who had it, or who are asking questions, it's really important to comment on this slow, gradual return to play. If you have it, don't just get out there and try to run through it. Really go through that self-isolation period. Don't hit the Peloton in your basement while you're doing your self-isolation. Just take those 10 days and rest. And then whenever you get back to return to play, take your time. And we still have to let public health lead the way. If there's lead the way. If there's an important message, some of these cardiac controversies, they shouldn't shut down sports. It's really still about letting public health lead the way. It's about mitigating viral spread. We don't want virus to spread among our athletes. We don't want our athletes to continue spread of virus. We know how to manage myocarditis. We know how to screen, or at least kind of follow some of these best practices at present. But listen to the public health people like Dr. Fauci. They really are the ones to listen to right now. Of clot, and that is actually, again, more prevalent in those patients who are sicker. So again, it's important to note that some of these questions you want to separate from the hospitalized versus the non-hospitalized patient, and there's many of these type kind of important questions that we don't know the answer to. There is a